The subject of the charter is high utilization of emergency services, with the health agency in focus being the Department of Health and Human Services and the leader being Robert F. Kennedy.
Whoops. There.
The background of emergency services usage. The specialty of emergency medicine is devoted to the rapid assessment and management of acute, unanticipated medical conditions or trauma. Emergency departments have always been the last resort. Staffed by interns or underfunded, emergency departments have had long wait times and subpar care for most of the past and remains true today. Emergency medicine wasn't a specialty for more experienced technicians to focus on until the lack of standard of care got the attention of the people. Only after the riots at Cincinnati General in the late 1960s did the hospitals begin their emergency medicine residencies in the 1970s. The is to rapidly diagnose and treat urgent and emergency cases requiring immediate medical or surgical help. However, problems with community health services are causing people, especially older adults and children, to improperly rely on the ED. Common misuse of the ER occurs when people seek care for minor ailments such as common cold or routine health issues. This usually happens because they don't have primary care, are looking for convenience, or are unaware of other appropriate options other than like the urgent care. Impacts of high utilization. Overcrowding in the emergency department stems from various factors, ultimately leading to a rise in patient numbers, increased mortality and morbidity, and a diminished capacity to deliver timely critical care for medical emergencies. There is an increase of emergency department utilization, but the actual number of emergency departments is decreasing. Emergency department overcrowding leads to systemic dysfunction, resulting in longer waiting and admission times, greater potential for infectious disease spread, and extended inpatient length of stay due to transfer delays. The groups who frequent the ER are mostly those who are unstable or no housing, racial or ethnic minorities, people with mental and substance use disorders, receivers of Medicaid or CHIP benefits, low income or unemployed individuals, and the elderly and infants younger than a year of age. These people make up the most vulnerable populations in our society. Increased strain on staff contributes to an already serious issue of physician burnout, resulting in poor workplace morale, higher turnover, and understaffed departments. A higher mortality and morbidity rate is reported in overcrowded emergency departments when compared with their not overcrowded counterparts. When overwhelming patient volume prevents ED from delivering care optimally, the consequences extend far beyond the unit itself. Patient safety and health outcomes are immediately jeopardized, hospital financial logistics and resources are overtaxed, and ultimately the community faces a weakened safety net. Emergency departments visits are disproportionately expensive to primary care, particularly for treatable conditions. The inflated cost is a direct result of the high facility fees and operating overhead. Specialized services like radiology tests and labs cost 10 times more at the emergency department and are major contributors to overall higher expenses for society.
All right. So, as far as what statistics there are to kind of bear out all of that information, um, this graph here is taken from patient emergency data from like PCR. So, like what people actually on the insurance side of it, they can look and see like what happened after they went to the ER. Did they get admitted or not? And then that kind of tells you how emergent or if it was really necessary that they were there. So 28% of emergency department visits were treatable in primary care, so they didn't need to be there at all. So that would be something very minor, a cold, sinus infection, something like that did not need to be in the ER. 33% did have a diagnosis, but it was something that could have been diagnosed outside of the ER. So by a primary care physician, a family doctor, somebody like that. And so that's over 60% combined of people that showed up in the ER did not actually need to be there. So the data does bear that out. It is being overused. Um, and this is, from the provider side of it, there are some points on the left there. So 85% of emergency physicians felt that too much diagnostic imaging was being ordered, which, as Marie just said, it's very expensive. It's 10 times more expensive to get those things done in the ED. And they said 22%, or sorry, 97% felt that at least some of the advanced imaging studies were not medically justified. And so then the question is, well, then why are they ordering them if they're not medically justified? Well, there's another study here or a survey that said 69% were for fear of missing a low probability diagnosis. So they're just trying to rule something out that they know is probably not there, but they don't know for sure if they don't do an image. And then fear of litigation is 64%. Those go hand in hand, I think. So doctors don't want to get sued, or they have heard a horror story about somebody getting sued because they didn't order a CT scan and they missed, you know, a stroke or some, major thing, and then they got sued by the family or the patient. And so they go, well, we'll just get it. Every time I see this now, I'm just going to get a test. But doing that drives cost up and overuse. So this next slide is patient reported. So that's on the physician provider reported and insurance company reported side. This one is interesting because 24% of adult ER visits this is people self-reporting that I didn't go to the ER for something that I knew it wasn't really urgent. I just needed a prescription refill. I just needed to talk to a doctor. I couldn't get in to see my doctor. I don't have a doctor, things like that. So, taken with the last slide, even if you take out, all of people, you could say people aren't doing it on purpose. Well, 24% of people are going, yeah, I know I shouldn't be here, but it's the most convenient thing for me. So data definitely bear out that there is an issue with overuse, and that is going to cause burnout and it's going to stress the system. As far as strategies to reduce high utilization, one I'd like to highlight on this page is analytics. So using claims or EHR data to identify patients with chronic disease burdens, behavioral health needs, and social risk indicators allows for proactive outreach. And that is true. And so there could definitely be programs where those risk indicators or chronic health issues are highlighted, and those people can be redirected before they end up in the ER and cause a visit that doesn't need to be there.
Another care coordination technique could be outpatient communication. Exchange of information, such as ED visits and shared documentation, enables care providers to follow up more promptly with their patients following an emergency department visit. There has been a push for outreach for ED communication between primary care providers to have a more effective approach on community care and safety nets.
Okay, and then some community and public health approaches. One I wanted to highlight was increased access. So when urgent care centers operate during typical after hours demand, non-emergent ED visits decrease. For example, a 17% reduction when UCCs are open. Medicaid visits specifically drop by 29% in those analyses. And so providing well-placed alternative urgent care options is especially effective for Medicaid and uninsured populations, and that could be one aspect to consider for decreasing utilization. So the agency we have chosen is the U.S. Department of Health and Human Services. The DHHS oversees over 100 programs that work to protect the health of Americans and provide essential human services. Their mission is to enhance the health and well-being of all Americans by providing for effective health and human services and by fostering sound, sustained advances in the sciences underlying medicine, public health, and social services. There are a lot of different ways to do this, as we mentioned in the previous slides, but we chose to focus on access to primary care. The Department of Health and Human Services will be a key organization in combating barriers to primary care. And it has two specific programs that I wanted to highlight and that DHHS oversees, and that is the Health Resources and Services Administration and the National Health Service Corps. The HRSA works to improve health outcomes and protect the health and well-being of Americans, especially in underserved communities and areas with poor access to care. And they emphasize and target investments that strengthen the nation's core health and healthcare infrastructure and play a vital role in improving access to care. The NHSC works under the HRSA to support more primary care, medical, dental, and behavioral health providers through scholarships and loan repayment programs, which incentivizes people to come work in primary care and serve in communities with limited access to primary care. And so the leader we selected was Robert F. Kennedy Jr. He is the current Secretary of the U.S. Department of Health and Human Services. His role is that he oversees all of the HHS programs, including Medicaid, Medicare, the FDA and the ones that I mentioned prior. He also manages the budget, can implement legislation, and respond to public health emergencies. I zeroed in on those smaller agencies again that are more specific to the problem. However, the issue of high utilization has a lot of moving parts and will require a lot of changes, which is why we chose to focus on a larger agency and a larger leader. Then with the National Health Service Corps helps with loan repayment and provides scholarships for people wanting to go to primary care, with the requirement that they will work in an underserved area. If this program continues to grow, more people will likely choose careers in primary care. And this helps because there will be more availability for primary care physicians. And so people can schedule appointments with them instead of overcrowding ERs for these emergent cases. And then HRSA also works to fund community health centers, which helps improve access to care as well. And what Kennedy can do to help is making sure these programs can get adequate funding to continue to provide and improve access to care. He can also work with Congress to develop healthcare policies that can improve access to care in other ways. And then as far as his leadership profile, he was recently appointed to the role this year, but has been showing some aspects of his leadership already. So as far as his positive qualities, he has shown a lot of desire to make changes. He has already proposed major reorganization of the Department of Health and Human Services, focused on 3 goals, which is streamlining the functions of the department, ending America's epidemic of chronic illnesses, and reducing taxes while improving where taxpayer money is going. He came in with a lot of big ideas and has been working to get them done, and shows he does have a desire to make changes that has been really obvious early on. As far as collaboration, the DHHS is a massive organization which requires him to work closely with many different people, which some say he has been doing really well at. And then commitment, he has stated that over time, bureaucracies like HHS become wasteful and inefficient, even when most of their staff are dedicated and competent civil servants. And this shows that he's really committed to his role and responsibilities. He wants to make sure that he, in his role, and the people in other leadership roles in the Department of Health and Human Services are doing it right and actually helping American people, showing that he's committed to his role. As far as his negative qualities, it's been shown that too much change can lead to instability. Like I said, he's proposed a lot of big changes, but if he's moving too fast, it can get a little risky and cause a lot of instability in the role. And then this quote says, "We have to be certain that we make changes for the betterment of the whole, not just to build our own personal legacies." So he also needs to make sure that this is for the overall improvement of the country and the country's health, and not just to make himself look good. He also has a tendency to promote misleading health claims, which raises concerns about his ethical responsibilities as a leader. Trust reflects the essence of ethics and integrity. A leader is only as effective as the support that his followers grant him. Gaining that support is not possible if the leader does not earn others' trust and loyalty. In his position, he does have ethical responsibilities, and people rely on him and his information. Thus, he should be really, really careful to make sure that the data he promotes is accurate, ethical, and beneficial.
All right, and that's our presentation.
It looks like Nick has. Oh. Sorry, I was starting to talk. I didn't know if you're still recording. Looks like Nick has joined us.
I'm still recording. One sec here.